Okay, let's unpack this. Today, we are diving deep into a topic that's, well, incredibly important for anyone working in health right now.
Absolutely. We're looking at what it really means to decolonize global health.
It's a phrase you hear a lot, maybe debated sometimes, and it really asks some big questions about the systems we all work in.
Yeah, fundamental questions. And we're exploring this mainly through one specific piece of work today.
Right, a paper. It was published back in 2022 in Global Health Research and Policy.
And the title is Decolonizing Global Health. What should be the target of this movement and where does it lead us?
And we should definitely acknowledge the authors, Kuite, Tang, Chen, Ren, Chen, Wu, Kai, and Li.
Yes, their work is the basis for our discussion. It actually summarizes discussions from a symposium they put together. It's really insightful.
It really is. So what's the main takeaway from their paper?
Well, the core finding, the big consensus they report, is that global health today still carries what they call colonial vestiges.
Vestiges, like remnants, leftovers from the colonial era.
Exactly. Patterns, assumptions, ways of working, and they argue these aren't just small things on the surface.
No, they're suggesting it requires systemic reform, really getting at the fundamental assumptions.
Precisely. And to understand that, you need a bit of history, which the paper lays out.
Okay, so where did global health actually come from? It wasn't always called that, was it?
No, it evolved. The paper traces it back, starting largely with tropical medicine.
Right, and that was primarily about protecting the health of the colonizers, wasn't it? Often not so much about the local populations.
Or sometimes even detrimental to them. Then later, particularly around the Cold War, it shifted towards international health.
Okay, international health. What defined that era?
A lot of aid flow. What we call ODA, official development assistance. Money going from wealthier countries, often the former colonial powers.
To lower and middle income countries, the LMICs.
Yes. But, and this is crucial, that aid often came with strings attached. Conditions.
Like the structural adjustment policies. From institutions like the World Bank, the WB, or the IMF, the International Monetary Fund.
Exactly those. And these policies often forced cuts in public spending in LMICs, including health budgets.
Which seems counterintuitive if the goal is health development. And this also fueled brain drain, right?
It certainly contributed. Skilled health workers leaving LMICs for better opportunities in HICs, the high-income countries. A real loss of capacity.
So you had aid coming in, but sometimes tied to policies that could weaken the very systems it was meant to support.
Which is why the paper uses that phrase, old wine in a new bottle. Even today's global health, with all its talk of equity and justice, can sometimes perpetuate those older power dynamics.
Okay, so let's bring it to the present. Where do the authors say we actually see these vestiges today in the day-to-day work?
They break it down nicely into 3 levels. The first is right there in daily practices.
Like what specifically? What might you as a health worker recognize?
Well, think about projects maybe being driven more by what donors want to fund rather than what the community identifies as the top priority, a lack of local ownership.
Or who dominates the conversation? Global health training, the big journals, major campaigns, even ICSOs, international civil society organizations.
Leadership and influence are still heavily weighted towards HICs, high-income countries.
And even national health plans, HSDPs, health strategic development plans can sometimes be heavily influenced, maybe even drafted by international players.
Yes. And the funding focus, too. Think about the huge push for infectious diseases, HIV, TB, malaria, vital, of course, but...
But what about NCDs? Non-communicable diseases like diabetes, heart disease, which are often the biggest burden now in many LMICs.
Exactly. The funding doesn't always match the burden. Another point is how international experts, even with the best intentions, can sometimes create dependency instead of building sustainable local capacity.
Okay, so that's the daily practice level. What's the next level the paper mentions?
The next level up is organizational and regulatory structures, the systems themselves.
Right, like aid agencies, who are they ultimately accountable to?
Often, primarily to the governments or donors back in the developed world who provide the funding, not necessarily first and foremost to the communities they serve in LMICs.
And in those big global bodies, the World Bank, the IMF, who holds the power.
Developed countries generally have a much stronger say, more voting power than LMICs, even though the decisions impact LMICs profoundly.
And leadership. Do we see enough representation from LMICs in key global health organizations?
The paper suggests there's a significant lack of it, still very much dominated by HICs.
Okay, daily practices, organizational structures. What's the third deepest level?
You mean the assumption that perhaps developing countries inherently lack the solutions. That expertise has to come from outside.
Precisely that. But the paper flips this perspective quite radically.
How so? It highlights the flow of resources out of poorer countries towards richer ones. Think resource extraction, debt repayments, that brain drain of skilled people we talked about.
So the argument is that this outflow often outweighs what comes back in as aid or expertise.
Yes, the point being that solutions and resources do exist within developing countries, but the current global economic system often facilitates their extraction. What comes back as global health aid can be fragmented, conditional.
Wow, okay. So for you listening, maybe you felt some of this. A project that didn't quite fit local needs. Struggling to fund work on NCDs, seeing skilled colleagues leave.
It connects these individual experiences to that bigger systemic picture the paper draws.
So what's the proposed way forward, according to the paper, if the problem is this deep?
The guiding principle they put forward is that real decolonization means tackling the global political economy, achieving more equitable economic ownership.
So it's not just about health projects, it's linking health tightly to socioeconomic development.
Exactly, and they reference the UN Charter's principle of sovereign equality among nations. It's about respecting that equality in practice.
Right. So wrapping this up, the paper leaves us with a really challenging thought, doesn't it? Something for you, the listener, to really think about.
It does. It essentially asks, are developed economies really giving back through aid, or was much of their own wealth and capacity built on the resources and labor drawn from developing economies in the first place?
And if you start from that perspective, what does it mean for how we approach health work, how we collaborate across borders?
Yeah, what does that fundamental shift in perspective imply for our actions, our partnership, our advocacy? It's definitely food for thought.